Hello students, now I will discuss with you chronic obstructive lung disease. Well, COPD is a common condition, especially in our country, and here I wouldn't go into pathophysiology or details of COPD. I will only discuss with you the exacerbation of COPD and how do we manage the exacerbation in our emergency department. So I will more focus on a diagnosed case of COPD, right, and how do we manage this when they present acutely in our emergency department. So what is the classical presentation of patient with COPD exacerbation? They have wheeze, they have productive cough, they have dyspnea on exertion, progressive dyspnea on exertion, and they have, let's say, tachycardia and hypoxia. They are hypoxic, they have increased heart rate, they have wheeze, they have dyspnea on exertion, and they have a productive cough. Okay, so this is this is how they present. Patient will give you a history that recently the use of inhalers, the routine use of inhalers, the inhalers which he has increased it. The change in the amount or color of the sputum, and a new requirement has started in him that he cannot sleep when he is in supine position. He has to sleep in upright position because supine position increases his dyspnea. However, none of these symptoms, right, are symptoms particular for COPD. There are so many other causes which can have the same kind of presentation. So how do I make the diagnosis that it is exacerbation of COPD or it is some other condition, some other differential diagnosis, right? So history is very important in COPD patient, and some typical physical examination is very important in COPD patients. Though remember that definitive diagnosis of COPD is not possible in emergency department. Okay? What are the typical symptoms of COPD? Cough, wheeze, chest congestion, fatigue, sputum change in sputum, fever, chills. So these are the typical symptoms: cough, wheeze, chest congestion, fatigue, right? And these are non-specific symptoms which can be there in so many other clinical conditions, right? And all these features which I discussed just now with you, these symptoms may vary from mild to severe. So spectrum of symptoms can change from mild to severe. The mildly affected patients may note mild dyspnea on exertion, and more symptomatic patient may complain mild to severe dyspnea even at rest. So the spectrum of disease from patient to patient vary on severity, and management is according to the severity of the patient. What is the approach for management in these patients varies. Some patient presenting with severe dyspnea may immediately require invasive ventilation. Some patients presenting with moderate dyspnea may get benefited from bronchodilators, steroids, etc., etc. So management differs according to the severity of symptoms. Okay. Now, causes of acute decompensation. Whenever we take the history, patient says he's an old case of COPD, is on inhalers, and suddenly things have become bad for him. His symptoms are increasing, right? We always should keep in mind to know for a exacerbating factor, something which has caused decompensation in this patient. So what can cause the decompensation? Because we not only have to treat COPD, the present exacerbated state of COPD, we also have to treat the cause which has decompensated COPD. So we have to target the cause also. So in history, we have to look for the cause. So what are the things which can decompensate? Superimposed infection. Any superimposed infection can decompensate. Patient smoking. Suddenly patient has increased the smoking, so it has decompensated the COPD. Then non-compliance to the drug, his routine drug and inhalers, he has become non-compliant. Lack of usual medication or oxygen therapy. right? Spontaneous pneumothorax. Patient may, COPD, the old standing COPD patients may develop spontaneous pneumothorax. So infection, smoking, non-compliance to the oxygen therapy and drugs, or pneumothorax can exacerbate COPD. So whenever we do physical examination, what are the things we have to see? To understand the severity of the situation, the first thing which we need to see is work of breathing. How much is the effort patient is taking to breathe? Because this will ultimately guide our management, right? If patient's work of breathing has immensely increased, patient will fatigue and patient can go into respiratory arrest. So we have to target those patients, and maybe we have to prevent the situation by an early intervention in these patients. So we have to look for the work of breathing. How do I see the work of breathing? I have to see it by seeing the accessory muscles of the patient. How much the use of accessory muscle? We have to look for retraction during respiration. We have to see the effort patient is taking during respiration. Patient is pursing his lip to take the breath. Patient is cyanosed, that is, patient is unable to achieve adequate oxygenation. And severity can also be assessed by during physical examination by seeing clubbing of finger, etc. Right? So there may be a finger clubbing seen in the patient. These are all telling us the severity of COPD. They are all pointing towards the severity. Increased use of accessory muscle, using pursed lip during breathing, clubbing present in the patient, right? And when we auscultate this patient, in auscultation, right? When we auscultate these patients, we can give variety of lung sounds, like we can have wheeze, rhonchi, even rals, right? Or we can have a silent chest. So such a wide presentation depending upon the severity. Severe bronchospasm, patient has absent breath sound bilaterally in severe bronchospasm. So patient may have silent chest. And because of inadequate oxygenation, hypoxia and hypercapnia, the mental status of patient is also impaired. Patient's GCS has depressed. Patient's GCS has, Glasgow Coma Scale has depressed. So during physical examination, I will also assess the mental status. These are the patients who may require early intubation and ventilation, right? So accordingly, the clinical features, we have to plan our management. Now, what are the investigations, right? What are the typical investigations which we have to do in these patients are also guided by the physical finding of the patient. Now, apart from features of clinical features of COPD, if the COPD is really bad, a long-standing COPD, then patient may have developed congestive cardiac failure. Patient may have developed right side heart failure. So during examination, we may get elevated JVP, we may get peripheral edema seen in the patient, hepatomegaly seen in the patient. They all are pointing towards the severity, right? Severity of the situation of long-standing COPD. Okay. So how do we start this management in this patient? We start the management in these patients by assessing the airway, breathing and circulation. Like any other patient presenting us in the emergency department, a COPD patient also with exacerbation is assessed in the same way: airway, breathing and circulation. We obtain the vital signs of the patient. We attach the pulse oximetry to see the saturation of the patient, right? And depending upon the requirement of the patient, we start our management. So we start in these patients with oxygen therapy. The oxygen therapy, we start with oxygen therapy. How do we choose the device by which I will give oxygen to this patient in COPD? Initially, always a low flow device is used, like a nasal cannula or venturi mask. Because remember, COPD, the respiratory drive, is dependent upon their hypercapnic state. So if I use a high flow device and wash out carbon dioxide, there is a possibility that the central respiratory drive of the patient will get obtended, right? So initially we use a low flow device like Venturi mask or nasal cannula. We avoid using high flow device, right, unless and until inspiratory flow, right, of the patient is very low and patient is not responding to the low flow devices, right? So they are dependent upon hypercapnia for their respiratory drive. So a very quick reduction of CO2 can be deleterious in these patients. Now number of these patients may not benefit with oxygen, simply with oxygen. Remember one thing, they are the patient in whom you assess and manage, do the management according to their requirement. You do a continuous assessment and management, and you do a reassessment and you change your management accordingly. So management is dependent upon whether the patient is improving from your previous intervention or not. So number of time we attach oxygen and observe for the improvement in the patient. If patient is not improving with one device, we can change it to the other device, and maybe patient may require a non-invasive ventilation, a non-invasive ventilatory support, or an invasive ventilatory support. We may need to intubate our patient. We may need to put the patient on NIV, on ventilator, non-invasive ventilation. Always we start with non-invasive. We put a mask, strap the mask, attach the patient to the ventilator and give a positive pressure ventilation through a non-invasive mask. If patient is deteriorating even with that, then only we go for invasive ventilation. We go for invasive ventilation. Okay. Okay. So remember, a quick decision is very necessary on what therapy would be best for the patients, right? So quick decisive therapy based on initial clinical assessment will yield the best outcome in these patients. Now diagnosis is most probably on typical signs and symptoms, right? And focused on supportive and exclusion criteria. Other things for other DDs are excluded, right? And confirmatory test not possible. Confirmatory test is pulmonary function test, spirometry test, not possible in emergency department, not in acute exacerbated state of COPD. So I cannot 100% confirm that patient is a patient of COPD, but based on his clinical symptoms and physical examination, he is most probably an exacerbated case of COPD, and we manage on that line only. Patient improve, right? Patient will definitely improve. Okay. Generally, the patients who present with COPD, exacerbated state of COPD, are older patient with a history of smoking, multiple comorbidities, right? So they have a broad differential diagnosis. They have a broad differential diagnosis, right? And we need multiple investigation in these patients, right? So that we rule out the other cases, right? So most serious, they may have a DDs of most serious other conditions presenting to emergency department. So what are the DDs in these patients, right? What are the DDs in these patients who come to us with breathlessness? It can be congestive heart failure. It can be acute coronary syndrome. It can be pulmonary embolus, pneumothorax, pericardial effusion, pneumonia. All these conditions can masquerade the signs and symptoms of acute COPD exacerbation. So all these can be a differential diagnosis of exacerbated state of COPD. So how do I rule out these conditions, right? How do I rule out these conditions? There are few investigations which we can do, though none are diagnostic. Chest X-ray, ECG, a BNP can be done to distinguish whether the dyspnea is because of lung condition or because of heart condition. ABG, serial ABG may be required, and cardiac markers may be necessary. So what is a typical finding in chest X-ray of COPD patient? Chest X-ray is one of the most common investigation done in evaluating COPD patient, and there are some typical findings. There is increased AP diameter in chest X-ray. The anteroposterior diameter would increase. There may be possibility of flattening of diaphragm. Typical COPD lung we will get. Decreased pulmonary vascular marking. Lung markings would decrease. And in absence of another acute abnormalities, such as absence of other acute abnormalities like pneumothorax, pulmonary edema, infiltrates can also be ruled out by chest X-ray, right? Even pneumothorax, everything can be ruled out by chest X-ray, which would be evident in chest X-ray. So, if in chest X-ray I am seeing a pneumothorax, my management would change in the in the direction of pneumothorax. So chest X-ray is really helpful because a lot of other DDs of acute exacerbation of COPD can also be diagnosed by chest X-ray. Okay, ECG is insignificant, but the important thing is that since this patients are typically they are typically old patients with a lot of other comorbidities, so ECG can help in ruling out the other causes which can present like this, right? ECG is very helpful in ruling out the ST elevated MI which can present like this. It can also rule out acute coronary syndrome, other acute coronary syndromes. In ECG, what would be a typical ECG finding in COPD patients? There are some typical ECG finding in COPD patient. One typical finding which is very typical for COPD patient in ECG is multifocal atrial tachycardia, very commonly seen in COPD patient, multifocal atrial tachycardia. So what are the common ECG findings in COPD patient? They have a low voltage ECG, right axis deviation and right axis deviation. P pulmonary may be there, peaked P wave in lead 2, 3 AVF, right atrial hypertrophy because of right-sided heart failure, tachycardia, multifocal atrial tachycardia. I talked about this multifocal atrial tachycardia, rarely present, but if present, typical for COPD patient, specific for COPD patient, right? So there is only one finding in ECG which is specific for COPD, is multifocal atrial tachycardia. Other are non-specific findings, would not much help in diagnosis. But ECG is important in these patients to rule out other causes which can present like a acute exacerbation of COPD, namely acute coronary syndrome. Okay. We always have to obtain a ABG in these patients, very essential, because ABG would help us in managing, evaluating the degree of hypoxia, acidosis and hypercapnia, and eventually in deciding our therapy. In these patients, not only a single ABG may be required, we may need serial ABG, and accordingly our management will vary. So what do we do in this patient? What is the definitive management of this patient? We always start with bronchodilators. We always start with short-acting bronchodilators. We always start with short-acting bronchodilators like albuterol, right? This is the preferred beta agonist which provide the most rapid response. And we go on giving this albuterol nebulization to the patient. We nebulize the patient with albuterol. We give multiple doses, then eventually a clinical response may come. So it is not that we gave albuterol, we wait again for some time, we can continuously go on nebulizing the patient with a short-acting beta blocker like beta agonist like albuterol, and until and unless we go on giving it to the patient, until and unless the response comes. So after oxygen, the most important thing in the treatment of COPD patient is bronchodilator. And the most important bronchodilator is albuterol, a short-acting bronchodilator, ultra short-acting rather, beta agonist, a preferred bronchodilator which is continuously given till the response comes. The only problem is, since it is beta agonist, the only limiting factor is these old patients, it will produce tachycardia and etc., which can cause ischemia, cardiac ischemia, etc. The cardiac workload will increase because of tachycardia, etc. So ischemia, etc. can get precipitated. So that is why we have to be very cautious, because we don't want even to tachycardia develop in these patients. But bronchodilator is the first line of management. Then we can go for anticholinergic bronchodilator like ipratropium bromide. Ipratropium bromide is also the first line of management, but unlike a beta agonist, ipratropium bromide is not given continuously. Inhaled ipratropium bromide is given every 4 hourly, right? And number of places they use beta agonist and ipratropium bromide together for the response. But studies have not shown any benefit of combining these two, right? But people are using even combining these two. There are preparations available of combined preparation available of these two also. So very important, you have to go for short-acting beta agonist, and every 4 hourly we have to go for anticholinergic bronchodilator like ipratropium bromide. Now another very good drug, important drug in acute exacerbation of COPD is steroid. Steroid is very helpful, and patients are started with IV steroids like methylprednisolone or prednisolone, right? This will try to control the inflammatory component, and optimum regimen is still not established for how long you have to give steroid. But 10-14 days steroid is given and then it is tapered, which is unlike bronchial asthma, in which normally 4-5 days steroid is given, right? But in COPD, exacerbated state of COPD, steroid is given for 10-14 days and then it is tapered. Many end-stage COPD are totally steroid dependent, and corticosteroid has shown to reduce the treatment failure in this patient. So steroid is important. So mostly in acute exacerbated state, steroid is started. But we always have to be careful for the complications of steroid. Since they are old patient, they may be diabetic, the sugar control can get impaired, their hypertension can get worsened, gastritis can happen, steroid psychosis can happen in them. So we have to be always keep in mind for all these side effects of steroid when we are giving steroid to these patients. Okay. Then another important stay in management is antibiotics. Empiric antibiotics is started because infection is one of the most important cause for exacerbation of COPD. So antibiotic is started. Right? In spite of bronchodilator, in spite of ipratropium bromide, in spite of steroid and antibiotic, if patient is not improving, then what we have to do? Patient is going into respiratory decompensation with CO2, more and more CO2 retention, in spite of all medical treatment. Then we have no other option than to go for initially for non-invasive positive pressure ventilation or invasive positive pressure ventilation, right? So the decision to initiate one of those adjunctive therapy, that is ventilation either by non-invasive or invasive mode, is based on overall assessment of work of breathing and not responding to the treatment. There is no such guideline at what PCO2 you will start ventilation, non-invasive or invasive, whatever. There is no such guideline. It is simply based on the exacerbation of the clinical symptoms and response of the patient on drug management. If clinical symptoms are getting worsened, patient is not improving on medical management, then we have to take a decision and have to go for ventilation, right? Non-invasive positive pressure ventilation is a mode of mechanical ventilation given by face mask, and that aids in oxygen delivery and decreases work of breathing. Now it is next logical step if the patient is not responding to standard therapy, right? So whenever I put my patient on non-invasive positive pressure ventilation, what is my target and why I have started? I have started this because of progressive worsening of the patient. So my target is to correct acidosis, right? Because of CO2 retention, patient is in respiratory acidosis, correct hypoxia, and we have to avoid high peak and plateau airway pressure, right? We have to ventilate the patient, right? And we also have to continue with medical management, right? We also have to continue with medical management in these patients. We have to go on using bronchodilators, etc. Also, intermittently, we have to give non-invasive ventilation and use bronchodilator in these patients, right? Because of bronchoconstriction and other problems, they have a very high peak pressure and plateau pressure, which again would make the ventilation very difficult in these patients. Plus, there is stacking of the breath in these patients, right? There is stacking of the breath. Whenever we do the ventilator setting in these patients, the expiratory phase of the respiratory cycle is kept bit prolonged, right? It is kept bit prolonged to give more time for the expiration to happen, right? So this helps the patient during ventilation. Okay, so these are the management of acute exacerbation of COPD. Now, how do I dispose this patient? How do I dispose this patient? Now, ultimate disposition of this patient depends upon the clinical decision and it depends upon the work of breathing, social support of the patient, and how much improvement we got in the patient. Well, after my medical management, if patient has improved, patient can walk around, can carry out his normal activity, patient is not desaturating significantly or becoming too dyspneic, right? Not becoming too dyspneic, right? Can be discharged to home. Patient who do desaturate significantly or become too dyspneic, right, for complete ambulation. When we ask the patient to walk around, they are becoming dyspneic or start desaturating, right? Then these kind of patients cannot be discharged. Remember, mild to moderate exacerbation of COPD after initial stabilization in emergency department are disposed to wards for further management. Severe exacerbated COPD patients who require non-invasive ventilation or invasive ventilation are disposed to intensive care unit for further management. So emergency department physician has to do initial management, has to see the initial investigations, and ultimately dispose the patient according to the severity of his symptoms. Okay, thank you.